when having been in and out of the government as much as with other firms and so forth, it's always been beaten into me that I just give a disclaimer. All the views that you're going to hear about are mine or from my work. They have nothing to do with the institutes nor GW nor any other public or private or federal agency that we may talk about. So what I want to talk to you about in an hour is one of the things that is the most dreaded, hated, most awful thing in the world. And in fact, if some of you are old enough in the room to remember Claude Pepper, I actually staffed for Claude Pepper when he was still alive, and he passed away in '88. And he was one of the heads of the not only the Rules Committee but also the Aging Committee in the House. And he told me once, he said, you know, the two most dreaded words in English is nursing home. So whatever we can do to get people to think about why those shouldn't be the most dreaded words, let's think about how to do it. And I will explain some of that as we go along. But because we hate the word nursing home, we've had to come up with all these fancier terms, which sometimes really are all just about nursing homes. So sometimes you hear people talk about post-acute care as compared to acute care. Acute care is hospital care. Skilled care, which is a certain type of eligibility under Medicare. Rehabilitation services, which is both for the aged as well as for the young. The new push in home and community-based services, although it's been around for a long time. Continuing care retirement communities, CCRCs, which are really much bigger in the East Coast than they are on the West Coast. And one of the newer games in town is something called assisted living. So we're going to use that framework to start to talk about this to begin to educate you a little bit more. So the goals are, we want to give you some background so that you'll have the sufficient information when you start to look at and write stories that you won't have a problem in defining what you're talking about, because it gets very confusing very fast. If you think the Social Security discussion that you just had was pretty impossible to follow and that you've been doing it all for a long time, this gets even worse. And if you multiply this by an 80-year-old trying to figure out what's going on, it's a real nightmare. So we want you to be able to interpret and add some of the concepts of health policy into the discussion, so you sort of know where we're going when we start talking about elderly and frail and disabled, which are different communities that are all involved in long-term care. So we want you, obviously, to be better able to communicate and write to your community about the key issues. And what I mean by that, you need to be able to tell the fiction from the facts and the scares. Scares are a tremendous part of long-term care. Am I going the other way? I'm going the other way. All right, so we will talk today about clarifying some of the confusing discussions. What do we mean by the care? Critically, who pays for what? The sense that we're living in right now, what I call artificial complacency, or another way of saying it is what me worry. And the impending age wave as to whether or not that's real or imagined. And the impact on all of this on the current labor force, which is one of the things that people just don't get. So when we think about long-term care, do we mean by long-term care all of post-acute care, everything that happens when someone walks out of a hospital? Or do we mean a whole bunch of services, whether it's skilled or intermediate or custodial, as people get older and frailer? Is that what we mean by post-acute care and long-term care? What are these new independent living apartments that you see about? What about some of that HUD housing? Is that really long-term care? What about people living at home? So when we look at home and community-based services, one of the other terms that has been around for about 30 years now is called aging in place. People want to stay at home. The buzzword, if you all like to have a nice abbreviation for aging in place, is NORC. Does anyone know what NORC? Anyone ever hear that? So it's a naturally occurring retirement community. New York City is full of them. There were condos and apartment buildings where 30-year-olds moved in 40 years ago. They haven't moved. Now they're 65 and 75. They're naturally occurring retirement communities. So what's happening in New York is that some smart clinicians are now putting nursing offices on the first floor and services right on the first floor of the apartment building to really service those types of individuals. DNA is the Visiting Nursing Association, which, by the way, also started in New York in this country back in the turn of the last century, and it was very upper crust. They only went to the best houses in the Upper East Side. It wasn't for folks who, as we think of the blue uniform public health nurses marching the streets with their little bag in World War II. That's not what they originally started out to be. And now we have things such as the home health care aide, and another individual called a homemaker who helps people do chores around. What is all this stuff all about? Who are they? So maybe in the course of the next hour we'll get a better sense of that. But here's also a second part, in addition to definitions of who does what, is about who pays for this stuff. You have private pay, you have Medicaid, you have Medicare, and you have insurance. We hear all about insurance, about long-term care insurance, disability insurance, and workman's compensation. And actually, in reverse order, that's how the services can get paid for in long-term care facilities. Meaning for the younger folks, which are 14% of all the people in nursing homes are younger than 65, is coming from workman's comp, accidents, and then disability. The biggest disability right now is really a function of what we call donor cycles. Anyone ever hear that expression before? A donor cycle is a motorcycle in the hands of an 18-year-old, and and all of the traumatic brain injuries we have. What happens to those individuals? Many of them end up in nursing homes. Next questions to start to think about to frame this is, when does long-term care start? Does it start at the end of a hospital stay? That's what Medicare would like you to think, because that's how Medicare eligibility works. But is it really when there's a need for supportive services? Is it all health care? Or are there some definite social needs that have to be taken place by family and friends and others? So when we start to see the whole compendium of what long-term care is all about, we find, well, how are we going to determine who needs it? So the old model was a medical model, and we determined long-term care need by diagnosis. Someone had a stroke, CVA, whatever, they needed to have long-term care. But what we found over the past 50 years, that diagnosis really has nothing to do with long-term care. Long-term care is really all about an individual's functional ability. How can they do stuff? Some people come back from, using the stroke example, from strokes much faster than others. Some have residual effects that they're never going to recuperate from. So we have two major scales that we talk about all the time. And if you don't know what they are, I advise you to go Google them and look them up and get to know them really intimately. There are different variations, as you might expect in any scale, because this is America, we have to have all sorts of different changes. But the two are what's called the instrumental activities of daily living. And these items are the items that determine, and are used to determine by social workers and directors of facilities, to determine whether or not we can actually discharge a person from the hospital home. Instrumental activities of daily living include such things as, can you make a light meal? Can you walk out of walking range, in other words, out of your house? Can you manage your money, which doesn't mean manage Social Security, it means can you do a cash transaction at the supermarket? Can you do some light washing and some light cleaning? And how can you actually survive in the community? A lot of us, mainly the men, think it's sort of biased because it asks all sorts of what had been traditionally called women's chores. So men automatically score lower on activities of daily living because most men don't have a clue how to turn on the dishwasher or the clothes washer. The activities of daily living are much more basic, and that really determines how you can live and whether or not you can even survive in a nursing home or need to go to a place like a nursing home. So activities of daily living are whether or not you can transfer from the bed to the chair, toileting, bowel and bladder training, can you do basic grooming, and can you feed yourself, which does not, unlike instrumental activities of daily living, we're actually making a light meal. Feeding in the activities of daily living means getting the food from the plate to your mouth. And on the activities of daily living, it isn't just an on and off switch. It isn't that you're just independent or dependent. There's gradations of such. So you can be have some, depending upon how you want to start, but if you're totally independent, you do it all on your own. But sometimes you need assistance, and that could be with a device, or then you may need assistance with a device and a person, or maybe just one person, and then you may need a device in one or two people if you're lifting somebody around. So those determine what, and then if you just can't do it, if you're a sludge, then you are totally dependent. I've done this all my life, and that's actually how I was going to start out a little bit about me. I'm the youngest son of a youngest son, and there was an age disparity. So by the time my father was 35 in the middle of World War II, before I was even born, my father never had to go to the war because he had 40 dependents. Thank God they had a big house. But there were all these people who were in the war whose kids came and stayed at our house. So I always thought these multi-generational big families were what everyone had in the world. And it wasn't until I got a lot older that I found out that there was this American phenomena called a nuclear family. But that was so alien to me. So to me, I sort of grew up in a NORC, I guess you could say, or places where there were lots of folks around all the time. Getting back to activities of daily living, there are what we call late loss activities of daily living. And that's the real trigger as to whether or not an individual needs to be institutionalized. So we talked about feeding and grooming. People are okay of letting some of that go, but actually transferring out of the bed and toileting are something that individuals really want to hang on to themselves, and so that's why we call them late loss. So if you have dependencies, or remember we talked independence, dependency, and late loss, you are the individual that's probably earmarked for some type of long-term care. Whether or not it's really institutionally based, or whether it can be performed in a community, is going to be a function of what? Money. How much money you and the community have. So when I talked a little while ago about who provides all this care, and we talked about individuals who are in nursing homes and assisted living and so forth, what you have to find out and know and understand and grapple with is that families and friends actually provide 60% of all long-term care in this country. And they do it for free, or at this point in time. They may not do it lovingly for free, but they are doing it for free. So there's an issue then about what really happens to get people from this volunteer doing it for free movement into the paid. When does that transaction happen? How does that transaction happen? And then when we start thinking about it, what's the real function of a case manager? Who's the one sitting there saying whether or not mom needs this or mom needs that? Well, as I gave you a sort of little hint, that for those who are not in the community but have to have a hospital stay, if they're in the hospital for 3 days, that's the magic number, 3-day hospital stay, and they have restoration potential, then they may be eligible for skilled care provided by Medicare. If not, they may be provided for private pay, free country. If you can find a bed and you have the money, you can do it. And so that has been the way it has been for the past about 45 years. But now what's happening, everybody knows about the Affordable Care Act, and that's putting, and will put, a tremendous change on what's going to happen with the way long-term care is going to proceed for everybody. The other group that's being very innovative, and I know there's been a lot in the press about the acute care part of it, but is the Veterans Administration. But not the veterans for everybody, not all veterans in other words, only those who are from the Gulf Wars, in other words the younger guys. So what the Veterans Administration is doing is that if a veteran can go home and have mom take care of him or her, then the Veterans Administration will pay for mom to take care of him and her. So it changes it out of this friends and families volunteer into the mom being the care provider. When that was being put together, the biggest problem was, and these are the things that trip everybody up, is simply the fact that most parents are currently working. If you have a son who's 23, you may only be 45. So if mom's going to stay home, what's going to happen to her job? It's gone. She loses her job, and in this country, what does she lose? Her own health care benefits. So what the VA has done is that if a mom stays home, or dad, or sister, whoever is eligible, they can then apply for, under the new GI Bill, to get CHAMPUS, which is the health insurance for for military families. So that's about the only way that that's happening. That's a new benefit. It's only been started for a couple of years. It's not extremely big at the moment, but of course, with all the veterans groups and veteran service organizations that are out there, the Vietnam vets are in there saying, why don't we get this benefit? And the GI Bill just made it earmarked for the Gulf Wars as a demonstration to see what's going to happen. So when we start thinking about, well, what's been the whole history of the world here about nursing homes in this country, here's one of the things that I always like to get people to think about. When I started doing what I do, was actually, I came here to be one of the little boys with the Carter administration. I was 10. At that time, there were about 16,000 nursing home facilities, federally certified nursing home facilities. And the number of residents who were living in those nursing home facilities was about 1.5 million. So if you do the math, it comes out to be the average nursing home size back in 1977 was 100 beds. But nursing homes, as we know them, were really a post-World War II phenomenon. World War II hit, the guys had been out all over the world and all over the country. When the war ended, a lot of them stayed where they were, so they didn't come back, and they didn't have the live in the world that I grew up in with this multi-generational and multi-family phenomenon, so we needed to have some type of nursing home to take care of the people who had no family. Most of them initially were county-based, and they were religiously sponsored. So that's when you had the Jewish facilities, the Presbyterians, the Episcopalians, and the gazillion different Catholic ones that were all around the country. They were state-owned and licensed, and some of them were actually had very strong state ties until the actual passage of Medicare and Medicaid in '66, which may put them much more into the federal purview. States still license nursing homes in every state. But Medicare is the federal certification that says whether or not this facility is good enough to provide care to be reimbursed by Medicare and Medicaid. There are many key laws in the United States, but for people like me in my business, one of the things I always point out to my students is that the Social Security amendments, not the bill, the Social Security amendments of 1972, Public Law 92603, Section 222, actually was the law that really helped nursing homes to design and put in demonstrations as to whether or not there could be alternatives to nursing homes. What about home health? What about daycare services and so forth? And it also increased the amount of incentives for proprietary organizations to get involved into nursing homes. Because remember we said there were counties and religious? Well, there weren't enough counties and there weren't enough religious, so we had to get the proprietary world in there. So that's basically what was happening from 1966 to where we are today, which is 50 years. So now with that is an understanding and the push that we're going to actually grow more nursing homes. In 2013, or 2014 as we are right now, how many nursing home beds, how many nursing homes do you think there are? Remember in 1977 there were 16,500 approximately. What do you think it is today?
100,000.
100,000 once? Want to get me on the names?
75.
75,000. A million nursing homes, okay. How many beds do you think there are today? Remember there were 1.5 million beds in 1977? It's exactly the same.
Oh, wow.
Are you serious?
I'm serious. The number of nursing homes is still 16,500. The number of people who live in nursing homes is still 1.5 million. All right, so I need to go back. All right, figure this out. Why do you think that happened?
They died.
That's an interesting answer.
Because they're expensive.
Yeah, the cost.
All right, that's all part of it, but there's really.
But we've been writing, at my newspaper, we've been writing about the expansion of nursing homes and sort of these nursing homes that blossom into these CCRCs.
CCRCs,
So I'm confused by that.
All right, well, here I'm going to start to explain it to you, and because there actually is a good story. First element, when we ask what happened, it has to do with the population. So the little secret is that the average age of admission into a nursing home, a skilled nursing home, is really about 84. All right, so if you go back 84 years or 80 years, what was happening with American history? The Depression era. Why is that important?
Because your birth rate fell, right?
The birth rate fell to what?
Lower.
The lowest it's ever been in the history of the United States. You're getting there. All right. So you want to, you can look all around the world. If you want to suppress the birth rate, have a depression. When you look at Europe and now and so forth, in the last 20 years, the birth rates have really dropped. So what happened at the end of the Depression era? The war. And how did we control births during the war? The men didn't come home after a year for a leave. They were gone for 5 years. They may have had another liaison somewhere along the line, but
a lot of people didn't go to war, though. I mean, a lot of people served in the U.S.
Yes, but still, the result, with the rationing of food and everything else that was going on, it was not a happy time. So that was one of the reasons that. One is the birth rate was really low, and second, the war continued on and the guys were away. And then also important that starting in the late 60s was the beginning of what we called assisted living. And assisted living really looked like college dormitories. They were on the first floor they had a dining hall, and the upper floors they had a one room that looked like your old freshman dorm from wherever you went to school. And more importantly, they were not regulated by the federal government. In fact, they're still not regulated by the federal government. They're regulated by the states. They may be licensed in the states, but they may not be licensed. And some states have chosen not to license them. So that's had a major impact on what's going on. And also there's been a tremendous growth in home and community-based services.
Why has not being regulated by the government had an impact on the slow growth, the low growth?
Because they don't have to fulfill all the requirements for a certificate of need. As well as for the what standards they have to perform. So assisted living, depending upon the state you're in, right, the only thing it has to provide, in my vernacular, are 3 hots and a cot and get you dressed in the morning. That's it.
But did that have an impact? Wasn't that about an impact on how?
Well, it kept the number of skilled beds down because more people went to assisted living.
I see.
Yeah, so the assisted living was allowed to grow a little bit. So when we look at long-term care then, if you're trying to figure out how big it is, my little bullet here says it's very big, and this is how big it is. And long-term care expenditures, just in the decade from 2000 to 2010, if you look at the cost in billions, it's gone from 96 billion to 183 billion. It's doubled. And as we start, and remember, the other hint, little clue in here, is that this is when the population is really repressive. It's down.
What does that include, that money? Is it like
anything that's been reported by states or folks that said that it was spent for long-term care? It actually came, these are all from CMS numbers of how much they calculate was spent in long-term care expenditures. This doesn't necessarily mean what the government paid, this is just what people reported that they spent. All right, so as we look at the problem, we're stirring up the pot. I need to add a few more things to make you even more convinced that this world is really a fascinating puzzle to start to play with. We're still back to the numbers of certified SNFs as being 16,500. With an average bed size of about 100. when we look at three key people in nursing homes, the administrator, the director of nursing, after all it is called a nursing home, and the certified nursing assistants, what do we see when we look at annual turnover, when we talk about a labor component? So if one of the hypotheses has been and proven over time is the longer the people stay in their jobs, the higher the quality scores will be. The administrator, on average, turns over 50% every year. The DON, about the same. But the CNA, who provides 90% of all the direct patient services, is over 100%. So that means for every person I'm hiring as a CNA, I'm going to be replacing in the end of the year. All right, so let me put that in perspective and pull in another industry for you, because at first I was so overwhelmed by that, I said that we'll never have a world here. But in the hospitality industry, we have a very major hospitality corporation not too far away up the street that's headquartered here in Bethesda, Maryland. I can't remember its name. But in one of my pals who is working there, and this is why, when they're training individuals to be the individual who makes your bed, changes your linen, and is the domestic, do you know how many they train for every person who is going to work for them, who actually makes it through the training and is going to go in? It's about 25 to 1.
We train 25 and 1 get in.
Yeah. Many of them don't like the work. It's heavy work, flipping those mattresses and doing that stuff. Also, when they find out that they may be doing a background check, that some people don't come back for day 2 and 3 and 4. So that business is geared up for a high turnover. Nursing homes aren't quite as geared up for that type of turnover, but similarly, that's why you have such a high turnover rate. The cost to replace a CNA in a facility, in other words, to go out and recruit, put ads in your papers, and get everybody organized, is about $6,000 of an individual. So that's an added cost that a facility is paying every year just to recruit. At the same time, when we look at people who want to be licensed nursing home administrators, the number has decreased by about a third of people applying to become licensed administrators over the past 20 years. Those assisted living, ALFs is one way of assisted living facility. You want more jargons, you have NORCs and ALFs and all this. ALFs is over 40,000, but the turnover rate on their staff is unknown. Why is there, in general, why is their turnover rate unknown? They don't have to report it because they're not state licensed or whatever. So that could be a question you have. So you can go to one of the assisted living in your area and say, and how many people, how long has the administrator been here? And what about these folks? So when you look at the business part of a nursing home, and this is how I'm trying to pull all the pieces together for you that really make it interesting. Except for the nuclear regulatory agencies, nursing homes are the most regulated healthcare business. You know, hospitals don't have a licensed administrator running a hospital, but nursing homes have to. The average size of a nursing home in this country is 100 beds with an average staff size of 100, a census on a daily basis of about 80, percent occupied, it used to be 95. And they have 4 different payment systems that are competing back and forth. Medicaid, private insurance, and private pay insurances and Medicare. Those are the 4. And then the average revenue of most nursing homes is about $3 to $5 million a year. So it's a good, strong, small business. Yes?
Do you know what the annual income is for a nursing home? You've got the annual revenue.
I guess I don't mean their expenses.
I'm sorry, I meant the profit.
I
mean, is there a margin? What's the margin between? Sorry, I'm sorry. It's late in the afternoon. Revenue and expenses. What's the difference?
All right. So if you have your revenue is the amount of money that you're pulling in expense. All right. So what you're asking is the margin. What's left over?
What's the margin for a nursing home?
How profitable are they?
Yeah.
Anyone have a guess?
not.
Pretty low.
1 to 2%.
Oh.
Wow.
It's like a grocery store.
Exactly.
What did we say at the time?
1 to 2%. And so that's why a lot of nursing homes will go into groups of nursing homes and have small chains so that they can have a better economies for food purchasing, for laundry, and so forth. They are not a wild money-making organization. Yes?
What is the average salary for these CNAs? Is it minimum wage?
Yes. Well, the goal is to get them to $11 within 3 years, and that's what the Department of Labor wants. How many of them ever stay there and get there that long? Probably not that many. So here's just to give you some of the confounding, and I was having a discussion with somebody the other day who didn't believe me. But if you look at who owns nursing homes, which is a key part of the factor, you have for-profit, not-for-profit, and government. And government are really the state or county runs. Remember I told you a few slides ago that counties were a big piece of this? Well, counties now are only really 6%, so you don't really, that's almost noise. But over the years, the number of for-profit, not-for-profit, keeps hanging in there between 20 and 30%. But we've had to entice the proprietary world with having some minimum guarantees of at least 2% profit to get them into the business. So you see that there is 66% of all the beds right now are still in the profit aspect. So when people start talking about nursing homes make lots of money, they can only make lots of money for a very short time period, because then they're going to be in trouble with they didn't provide enough services, and they're yes.
I was taught is, you know, if you're going to buy a business or you're going to invest, you should, a 1 to 2% profit isn't worth the risk. I mean, if the UPS guy trips and falls on the front step, that wipes you out for 10 years. So how are they attracting capital? I don't understand why anybody does business for. I understand why Kroger or, you know, a supermarket might, because they're getting a lot of volume. But if the market isn't growing and the profit.
Do you think this could be one of the reasons the market isn't growing? Because the margin is so low, and yet we're required to have certain ways of taking care of seniors, so that's what we are permitting to have happen.
I just wonder if anybody's done any surveys to see who these people are. Are they saintly do-gooder types? Are they business masochists? What is the?
Aren't a lot of the for-profits, aren't they a lot of them publicly traded?
They are publicly traded, and but they may also own other elements. They may be an organization. For example, a big one that is Kindred, and Kindred actually has rehab hospitals. It has a whole bunch of diversification, and some states do allow the diversification of business. Some others do not. So it's a function of the state. So I tell everybody that when we talk about Medicaid nursing homes, there are 53 different types, because we have 53 different Medicaids in the United States. And similarly, we have more than that with the aspect of the types of services that by the states that people are allowed to have. So it's nothing standard. It's nothing that we can say uniformly it works across the country. It's a mess. And yet, people say, are they saintly people who are doing this, or are they masochistic people who think they can make extra money, or what's really happening with the perspective? And it's all those, and it's all, in my mind, really a function and derived by the state of and I call it the political will of the state. Does the state really want to do this or not? And that's really a topic for another long time. But let me give you some more aspects of how the pricing works. On skilled facilities, if you're in a small area, on an average cost, if someone's there for a whole year, it's between $60,000 and $120,000 per year. So it's not cheap. Assisted living, remember the a la carte plan, the 3 hots and a cot, that's anywhere from $40,000 to $60,000 a year. And then assisted livings may have an admission fee that you pay before you get in there, which can be all the way up to $1 million in cash. So how that works is that if you sell your house for $1.2 million, you take $1 million in cash and you go to your CCRC or assisted living and you give them $1 million. You're still going to be paying your $3,000 to $5,000 a month to live there, but you have this nest egg of $1 million, and when you pass away, that $1 million will then return to your heir. So it becomes really a corpus. And then if you just want to give them the fee to pay to walk into the place and never see that money again, that's about $300,000. So that was the whole model that that industry was built until 2009, when the WWFC hit, which I never heard that expression until I was overseas last summer, and the Europeans all call this the worldwide financial crisis, when all the real estate markets dropped. Then when people were selling their houses, they didn't have that $1 million, so they had to come up with other models to try to figure out how to survive. I will tell you that most CCRCs now are struggling with the cost of everything. Home and community-based services, after people finish their Medicare eligibility, which is rather generous, it's what the market will tolerate and how many services the people will use. So let's talk about, now that I've opened the door about money, how do we pay for long-term care? Well, we all pay for long-term care, all of us around the room, because we're all paying in our taxes or having taxes deducted out for your Medicare. There's Medicare payroll tax deduction. There are premiums that people who have Medicare are paying. There's our payroll deductions. There are general tax revenues in most states that actually support Medicaid, and then there are the different insurances. The long-term care insurances, the workman's comp, and the personal health insurance or disability insurance that people may have. Long-term care insurance, the jury is still out on that. It's very small. The use rate of people putting in claims for long-term care insurance, we don't have enough history as to figure out what it is and how it's going to work. So then when you look at private pay, Medicare, and Medicaid, what's the percentage of when you walk into an average nursing home you expect to find? And you'll see that 40 to 50% of the payment is paid by the individuals in those beds out of their own pocket or out of their savings. Medicare pays about 10 to 20%, but more likely it's they have 10% of the days and 20% of the revenues, because the Medicare rates are much better than the Medicaid rates. The Medicaid rate is also about 40 to 50%. And those are the rates that are really problematic, to the extent that for some states right now, the largest item in the state budget is their Medicaid bill. More than the roads, more than the schools, whatever. And you can look at your own state budgets to figure out what's going on. So then there are other hidden pieces about how Medicare works. Medicare Part A is for acute care, right? It's for hospitals. But Medicare for hospitals doesn't pay the first day. You pay that yourself, or else you have Medigap insurance that pays for it. But for SNFs, remember that 3-day stay, and you have to be able to have care and be restored? The benefit is for 100 days per spell of illness. The first 20 days are paid for at full. Days 21 to 100, if determined medically needy by the clinicians, you pay a copay each day. The copay is $152 per day this year for a total of $12,162. So this is another type of tax that we're actually putting on the seniors right now that a lot of them don't know. But you know, it's a miracle out there, and I've seen the miracle. The miracle is that when we look at the average length of Medicare stays, we see that orthopedic, which are usually knees and hips, they're gone in 20 days or less. They see the light. The people don't want to pay the money, and they're cured. CVAs, on the other hand, are a little bit, they're about 32 days. So people are willing to pay another a few thousand to keep make sure that that service takes place. So it's not as free and fancy and clear as it is. We have done, AARP has done, you probably answered that lots of people in the United States think that they have long-term care insurance because they're covered by Medicare, and they just don't. They have benefits for that first 100 days provided there's a spell of illness. Medicare B is an option. You don't have to sign up for it. It's for physician and other personal services. Medicaid, though, thinks in many states, maybe yours, thinks it's so important that the Medicaid pays the Part B premium for their patients, for their dual eligibles, so that they're eligible to be reimbursed under Medicare Part B, a little what we call classic cost shifting. Medicare C, which has only been really a hit on the West Coast and is now showing, it's also called Medicare Advantage, is the HMO for option, and it's run by private insurance companies. And the data, the studies that are now coming out saying that actually the Medicare C option may be more expensive than the current A and B combined. Medicare D is the pharmacy option that's still relatively new. It's extremely confusing, and that as the drug benefit. So myself and one of my colleagues were going to do a public service for the district, and we were going to go to the churches in the district when Medicare D was coming out. And after services on Sunday, we were going to tell people, you know, what meds do you take, which formulary could you use, which plan should you sign up for Medicare D. And the general counsel of GW called me into the office and said, can't do that. And the aspect is that if we had a student or me gave them the wrong plan, the university would be liable for, and so the liability issue was much greater. So here we were trying to do a good thing, and you know, no good deed goes unpunished, so to speak. So adding to all this confusion, the data suggests that 20% of everybody over 65 is going to use a nursing home sometime in their life, a skilled nursing home. But only 5% are going to use it for more than 90 days. Right? Everybody else is going to go in under that 20 days, hip, knee, little CVA, you're out. And so by and large, you're covered by Medicare, at least for now. So who is in for the long stay in the nursing home? We find they're the females, 84 plus, and they need nursing supervision. The easiest thing to think about of what defines someone as needing nursing supervision is a diabetic who's on insulin, or anyone else who needs to have an injection. Because if you're in a nursing home and have an injection, it has to be supervised by a nurse. You know, you just don't walk in and shoot yourself up. Well, maybe some people might want to, but that's not the way the liability works. So this is the group who are the frailest right now and are actually needing the services. People don't understand that we spend a fortune in regulating nursing homes. I already talked about certification under Medicare and Medicaid. States do the licensure. They do the licensure not only of the facility, but of the administrator and all the other PTs, OT, speech that are there. We also have an ombudsman. Have you ever worked with your state ombudsman to find out what problems are? And that would be one of the people I would definitely call. Every state has one ombudsman who's paid, and then they probably have 150 who are unpaid volunteers, usually retired attorneys, who can really tell you where the problem nursing homes are and as you're looking for stories. On the local level, the fire department and sanitation is really critical, and they also do their inspections to make sure that no one's putting trash out before 7 in the morning and all the fire codes are being met. Until 1987, when the Omnibus Reconciliation Act, or also called the Nursing Home Reform Act, was put into place, which is now 25 years ago, there were no mid-level sanctions for a nursing home. You were either Medicare, Medicaid, or you were out. We either were going to roll all the people out onto the streets, or you were saved. I know most of you aren't old enough to remember when some of that was going on, but literally it never happened. It happened in 1 or 2 facilities in New York. And so what did we do? We always had give you one more chance, give you one more chance. It's like dealing with a recalcitrant child. But in 1987 we said, okay, we have to have some intermediate sanctions. We have to have some way of hitting the situation. And so since 87 there's been many different types of sanctions, of trouble benefits, triple penalties rather, of what's been happening. The most important and most difficult punishment to give a nursing home is to make them suspend their Medicare admissions for a month or so. And the reason you would do that is that you're not closing them down, but remember I told you that 10% of the people and 20% of your revenue is coming from Medicare. It gives you gives the nursing home operator a nice little tap to say, you got to do this, 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 and come up with a plan of correction. And so that has been one of the most effective. I always get asked about where are physicians in all of this. And we have in this country, we're very fortunate to have about 750,000 physicians. How many are board certified geriatricians? So I called them up and said, how many board certified geriatricians are you? And they wouldn't give me an answer. So I said, okay, I've got to think of some other ways of coming up close. Every physician who is probably doing a board certified should belong to the American Geriatric Association, it seemed to me. I called them up and they said, we only have about 4,700 to 5,000 members, approximately. You know, this is off the record hearsay type thing. And then every nursing home has to have a medical director. So there's a society of medical directors who have about 5,300 people who belong. How many nursing homes are there? 6,500. Shouldn't everybody have a geriatrician as the medical director? Is taking care of older people such an anathema that even physicians don't want to do it?
And is there a role for RNs? Like, where are nurses in this picture?
Well, interesting question. We used to have a specialty called geriatric nursing. Gone. We got rid of that. We now have adult nursing. Because even the nurses didn't want to be certified as geriatric because they thought that would put them into too much of a bind. So the nurses are really a key player in this, especially the nurse practitioners. But I didn't want to get there. That's a much longer story, but they are key.
But CNAs are not.
CNAs are not licensed. And I mean, the turnover rate of CNAs, as we said, is like a boiling pot that, although they're crucial for day-to-day care, think about this. Do you know how many hours it takes to be of training to become a certified CNA?
75.
80, actually. So 2 weeks, then you can take care of grandma. That's okay. That's good enough. And although we've gone to the agencies on and on, licensing saying we think it needs to be more, we never win. So what I want to end with really is giving you some thoughts about what's perfect for me, because that's what it's, in many ways long-term care is all about. And when we look at nursing home administrators, in 1950, you got a license for being in situ, which means in the seat, in the old Latin expression. So if you had the job as a nursing home administrator, you got a license from the owner of the nursing home, you went to the licensing agency, they gave you a license. That good? In the 60s, we actually started a correspondence course to get people to understand what nursing homes were all about. In '66, that changed with the Medicare requirements. That changed everything about how nursing homes needed to be run. At GW, we're very fortunate to have a master's level training program in nursing home administration. Do you know how many schools have an accredited program in nursing home administration in the United States? 5. We're one of the first, and actually one of our compatriots who started with us back in the day was University of North Carolina, and it's now closed its program. So here's Duke, Hopkins, USC, and North Texas, and those programs are all teetering because once the senior faculty members who knew this are leaving, they're not being replaced.
How big is your program? How many students do you have?
How many students do we have? I bring in 25 students every year in healthcare administration. I have 3 that are earmarked for long-term care. And I have actually scholarship funds available for them. So the aspect of trying to get people to be in this business is really difficult. So the good news is it's not a business that's going out of business. It's going to be a need. The bad news, though, is that because the perceived occupation and the prestige of the occupation is so low, it's dropped. And that here's the real problem, too, is the aspect of indifference. When we talk about when people need long-term care, the boomers, as you know, the age of the boomers today goes from age 50 to 68. Boomers are not going to need services for another 12 years. So 12 years from now, or a little bit more, is when all of us who are boomers are going to be saying, where's my bed in the nursing home, or where's somebody to take care of me? And because it's so long down the road, we don't know what's going to happen. The impact of health reform is just not clear. I mean, the demonstrations and the pilots with CMS are just beginning. The affordable care organizations are not clear how they're going to be established, who's going to lead them. If we have bundling payment, is all the money going to go to the hospitals? We already said long-term care will not go away, but services and service providers and all those elements that we have are just really being tremendously different. The models are changing. The likelihood that we'll have more opportunities for NORCs is really fascinating. I've been to demonstrations where Microsoft and their gang have now chips that you can put into your TV. And so the TV can go on. It can be your late husband coming up saying, Susie, it's time to go have a cup of tea, get out of your chair. It's just to get people to be active and mobilized. Or you can have a movie star do it. The nonprofit world of PostAcute Care had their first Hack Fest, where we brought together a whole bunch of, 5 of my students, 5 software engineers. Every team had to have an academic, so I was in a team. Every team had to have an individual over 80 in the team to be able to see if they could use the software. I sit on the board of a CCRC in the area, and 90% of our of 1,400 lives, I mean it's not small, and 90% are on the internet or on their system every day. So I mean the aspect of saying older people aren't using this, the current stuff is just not true. Is there a lack of funds? You can argue that 6 ways to dawn, and that for some people it will be. Is there a lack of staff, and where are we going to get the folks, and how are we going to encourage them? That is the problem. So who's going to take care of me? How do we encourage careers in post-acute care? Have you ever thought of doing a story about having the high school kids get involved with the nursing homes in your area? One of the best nursing homes I ever went to actually was its backyard was abutted the local town sport field. Those people are out there cheering those high school kids where the parents were never there because they were working. They all had adopted a grandparent, and they knew the kids on each of the teams. They loved it. So it's the attitude that really needs to be changed. We need to move the world away from that aspect of the dreaded words of nursing homes. I think nursing homes and all post-acute care needs to be integrated. And again, it comes down to, in my mind, values. How are we going to get the value of older people and nursing homes to be positive in our culture when we look at the way the way advertisements and TV is done? There's a awful problems, personnel shortage. We're talking about turnover, all the regulatory things we're doing, the limited insurances, ownership that you mentioned a little while ago, how to raise capital, tremendous problem. And yet we have the growth of other options of assisted living and home and community based. Should they be integrated services? Should they be something that's much more together? I tend to believe that, but some states don't permit nursing homes to own community, home and community-based services, and there's such a stovepiping of the situation. So here are the 3 solutions that we have. One is the market forces. Just let's see what happens. And there are awards and rewards, and it's good enough. The real American way, and the reason that this industry is so regulated, is because of fear. Somebody falls down in a nursing home, let's pass another regulation. Every time you turn around, so, oh, let's pass another regulation. So that our regulations are spawning regulations. So what we really need to start to think about is how do we recruit and focus on recruitment and retention for people who really want to do this and get in this line of work. How do we move out of these sacred silos? How do we get to expand not only GW's capacity, but other universities' capacity? Why is it that everyone's okay with the point that 60% of all our post-acute care is proprietary? Is that really the American way? What do you think about that? I'm not saying it's bad, but why is it that we have let that really grow? We know for assisted living are now going to be mini apartments with all sorts of increased amenities. The real buzzword that you'll see in assisted living being advertised, not so much on health, on sickness services and so forth, but wellness. Do they have all sorts of services to keep me well? I'm not going to go there if they're going to get me ready to hop in the box and get underground pretty soon. So, And is there a type of residential character? How does that really work? Is that what I really want to do? I have some statistics on Alzheimer's, and I really don't want to go into that, but that's one of the, just to show you how big a problem that is, it's different because they actually take a whole bunch of different services than skilled facility services, but many people really put them in and think them being the same as nursing home. We do know that for folks living in nursing homes, the long-term stayers, those over 90 days, that there is a tremendous number of those, maybe 60 to 80%, who do have some type or experience some type of dementia, but we're not sure. Questions I usually get asked about long-term care insurance. I know time is running. Should I buy it?
Let me just tell you, you have 15 more minutes.
Oh, okay, got it.
75 minutes, not just an hour.
All right, got it.
So take a breath.
All right, long-term care insurance. Everybody asks me about long-term care insurance. Long-term care insurance is a good idea in general. But one of the things that we have found initially with long-term care insurance that drove me personally crazy, that's why I had to put the disclaimer first, is that if anybody calls you up and wants you to buy long-term care insurance, I have the one key question that you need to ask them. And that question is, how much is the commission that you're going to get for selling me this policy? And when long-term care insurance first started, the commission was 2 years of premium. So it meant for the first 2 years you were paying into the long-term care insurance. That's why you couldn't collect, because you were putting the money right in that guy's pocket or woman's pocket. So if they thought you were a hot to trot to buy this stuff, that's why they never hung up the phone on you. They're going, well, yeah, I'm going to get $20,000 commission for selling this policy, or $10,000 or a year. So when I've worked it with planners and so forth as we go forward, the number they came up with a few years ago, and I've yet to go back to get it updated, but I'm sure it's more now. But 10 years ago, they were saying, if you have, or mom or whoever has an asset portfolio of basically $600,000 in cash, then you need to have some sort of asset protection, whether or not it's a trust or whether or not it's insurance. Because the insurance on long-term care insurance is not to protect, it's not to pay the services, it's to prevent you from spending down your assets. It's a little bit different when you think about it. Because if you have $300,000 and you don't have insurance, you're going to have to pay part of that $300,000. So if you have insurance, it's to protect that kind of that corpus of money that you may have been planning to send to the next generation. So, should you buy long-term care insurance? Do the math for anyone who's really doing it. Do you have that $600,000 in cash? And when I mean cash, I mean liquid stocks and so forth, not houses, not your own house, not your own personal property, but things that that if you had to go into a nursing home or had to spend down from Medicaid would be used right away. Again, ask what the commission is. You might be really surprised. And then what I do recommend is that if you belong to a group and there's a group policies tend to be the better of all. So if you are in a large group or a union-based group or the government group, then long-term care insurance may not be a bad, it may be very affordable. Buying it on as an individual is not affordable. But if you belong to some of the groups, some of the union groups and so forth, not only can you buy it for yourself, but you can buy it for your parents. So you can spread it around your family. So you need to have everyone look at what kind of services that are available for you. So what's really next?
Can you tell us what the premiums are? What are the, like for somebody in their 50s, somebody in their 60s? What?
No. And the reason I say that somewhat cavalierly is that it's like buying a car where every time you turn around they're adding another option to it. And so one of the items that's expensive is that it's cheap if you just want to have, well, it's cheap relatively speaking, if you just want to have it be used for nursing home services. But if you want to have a benefit to be able to be transferred, to be able to have home and community-based services, or you want to be able to use it for assisted living or other organizations, then that keeps adding to it. Do you want to have a wait time of 90 days before you collect because you may have disability insurance? Or do you want to have 180 days, which would make it cheaper? So there's a whole configuration of where it is. And also in your 50s, it's going to be much cheaper than when you're in your 60s. But everyone's projecting that if you're going to use it, you're not going to use it to 85. So they're looking for a minimum of a 20-year given a growth period for your money that you're putting in. So it could be a plan that could be as low as a couple hundred a month to as high as like $2,000 or $3,000 a month. So which is another reason why if you're protected by a group and they know that a good thing about a group is that what happens in the group, a whole bunch of you are going to die and you're not going to ever claim, and they're going to have your money that they can then spread out among other people. So actuarial rules and so forth are really weird. All right, so here's the two things I want you to really remember. I keep seeing it referred to as a tsunami of people who are older, the baby boomers. So the first question I have is, how many people live in the United States? What's the total population of the United States? Roughly.
300
million.
Yeah, 300 million, 310 million. How many baby boomers are there?
72.
72 to 75 million. Big percentage, right? Now the baby boomers, I told you, are only go up to age 68. But we know our 85-year-olds are growing faster than any other group. So when you put us all together, it's almost 25% of the folks of the United States are rapidly hitting the age for services. So this tsunami in the next decade is going to be more than anyone is really anticipating. So what can happen is that there can be another type of WWFC, and that is you're going to have a lot of people with a lot of money to be able to buy a few services. And when you have people with money to buy a few services, what happens to the services? The prices go up. So therefore, to be able to be competitive, to be able to buy the services is going to be, for many people, problematic. But we, who know what's going on, are telling everyone, well, you have to keep a sense of humor on this, and maybe that big house that you have right now isn't going to be your big house for the rest of your life. And maybe you need to start thinking about some other ways so that you have cash that's competitive to be able to get the services that you want. So the Institute of Medicine, for example, is telling us in the next 10 years that the primary care physician that we have today and know about today is probably not going to be there, right? And in their study of nursing, they're telling us that the new primary care physician is going to be the nurse practitioner. So those are the programs. That's where we're going to go to get our fall down boobies and stitches done and so forth, and the physicians will be taking care of other things. But it's going to be a tremendous change in how the world really thinks about all of this and what we're going to be doing. So as writers and as newspaper people and features, I think that it would be great just to get folks from your community to really get them to talk to you about what they think is going to happen. And because now you have a little bit of some of the seeds of what could happen, that how are you going to go and make them think responsibly about what the next 10 years, what the next 15 years are thinking about. Here in Washington, if you talk about something that's going to happen 12 years from now, you don't get much traction. Presidents only last for 8 years, and senators 6 or 12 or whatever. So thinking 20 years out from now, or even 12 years out from now, is really a stretch. But I think in communities, when you're looking at the people in your own community of who's doing what and how are we getting people together, I think that becomes important. So I have almost 8 minutes or so for questions. I always get asked, how can I deal every day with something that's such a grim subject? And I personally don't find it grim at all. You know, I think this is the challenge of our generation and in the future of how we're going to take care of ourselves and each other as we move forward for the next 20 years. Yes?
I'm curious, you said that the Affordable Care Act, the implications of that are unknown. What are some of the possible scenarios that people are talking about, how it could impact it?
Sure. One of the big ones right now is that there may be a bundling of payment, which means that if you go to the hospital for stroke, CVA, then the government, under Medicare, the government will write one check. And that check not only pays for all your hospital, it pays for your physician, and it pays for your post-acute. So even though the post-acute may not be at all related to the hospital is going to pay for your post-acute services. So how do you think that's really going to look? What does that happen to the current nursing home world or home and community-based services now? Are they going to be scrambling and will take deep discounted rates in order to survive? Or are they going to be finding people, CNAs, who give them their 80 hours of training off the street to be able to take care? That's what they want. At least with the Affordable Care Act, they are permitting demonstrations, and another word that's crept into their vernacular is pilots. So states right now are trying to determine what kinds of pilots they want to go for, and whether or not they need special waivers from their Medicaid state plan or not is all being determined and talked about. So nothing's going to happen overnight, but within a few years, a lot of these things are going to happen.
That'll be driven at the state level.
It's Medicare is going to push them down to the state level, especially for the dual eligibles who are Medicare and Medicaids. Yes.
You kind of skipped over the Alzheimer's, but that's a key part of the whole equation for people going into nursing homes when people can't care for someone who has Alzheimer's, and then the care is not very good in a nursing home. Can you address that?
Yes, I can, and I don't mean to laugh. The issue is all mental health services in the nation are very poorly staffed. And for seniors, older people who have mental health services and mental health problems, there's virtually no care. And so when we know that a lot of the long stayers in nursing homes have a type of dementia or other mental illness, it's really problematic. And when you look at the numbers of 400,000 people right now who are suffering from that, and of the numbers of people who are over 65, people aren't really paying attention. We're also not training people to take care of them, both from the nursing side, the physician side, and even the administrative side. It's just not for many people, considered to be a financial component. I do a section on aging for all our medical residents, our first-year medical residents, and I have about 40 in the class, and I go around the room, and we're much better. I mean, with diversity, and the majority are women now in med school, as you may know. And I ask them what they want to be, and virtually they all want to be like pediatricians or internists. So in the pediatricians, I say to them, well, how many languages do you speak? And they sort of ruffle up and go, well, I speak English. And I said, well, you won't have any business. The only people having babies are minorities. So if you're not speaking a couple extra languages, then you're not going to be able to deal with your... and I said, how many people want to be gerontologists? I said, this is where the population's going. I get 3. And then one of the gerontological guys stood up and said, do you know that the fellow fee, the money that they're paid, is 20% less if you want to go into gerontology rather than going into some of the other fellowships? So we start the negative incentives right from medical school with what to do with seniors. So it's considered to be not as cool as doing other parts of medicine. Yes?
Do you have a forecast of what the shortage is going to be at the peak of the baby boom?
Shortage of what?
Nursing beds, SNF beds. Or are we just going to keep hiding them in assisted living, and you think?
Right, because and we may not have to hide them in assisted living, because what's really, I think the next thing we're going to grapple with is that maybe Medicare Medicaid in some states pays for assisted living, not in all states, but Medicare does not. So maybe there'll be an expansion of payment for those who have the 2 or 3 dependencies and ADLs that will give them some money to do that. I also believe, by the way, and a lot of people hate me for this, one of my titles is that I'm the Friesen Professor of Healthcare Administration. Gordon Friesen was a guru back in the 60s that actually talked about the design of hospitals and nursing homes, and he was the one who threw away the nursing station because it was just a place to hang out rather than provide care and services. among other things. But a few of us really believe that nursing homes and parts of hospitals should only be built for 25 years, because that's the life of, if they're really being used well. And then the world is going to change with changes in technology and so forth that they really need to change. So that's why I didn't want to give you a smart answer and say that yes, there'll be a shortage. I'm hoping that there'll be some tremendous rebuilds over the next 20 years. Yes?
What's driving, we've seen a lot over, I would say, over the past decade, maybe not quite that long, but roughly that period, sort of this explosion of memory care facilities that specialize specifically in care of people with dementias, Alzheimer's.
Right. And you're asking why is that?
Yeah.
Okay.
Obviously, the economics must be there, right? I mean,
well, they are, because the fact that we don't call it mental illness or dementia means we're talking about an upper middle class a group of people who have the cash. And if you look too at who's owning and running those memory care units, they're typically the hospitality world. So they're the Marriotts and the Hyatts and so forth that initially started into it. Marriott's pulled out of it now because it realizes it's moving into other. But it's when I talked about funds or not, there are a lot of wealthy people who are over 65 who can actually afford some of those services.
You're kidding me. That's a lot of money. I mean, that's got to be.
Well, if you sell your house for $1 million and you're going to pay $100,000 for memory care, that gives you 10 years.
Well, that's a good point.
And then you throw yourself down the hill or whatever. Not quite that bad, but I wonder about these things too. Okay, I guess we have time for 1 or 2 more questions, and that's it.
I just wondered, did the AMA not want to give you the number of geriatric doctors, or they said they don't have such a figure?
It was a little bit of both. I think they're almost embarrassed because the physicians. The problem is this: physicians are trained to cure people. They don't do very well with end of life, and so for physicians to have to gear up to this is a way we're getting people ready to transition to death, is many physicians see that as failure. So that's really part of the argument. So counseling, the social workers, the nurses and so forth are much more attuned or trained into what's going to happen with life's transitions. And you don't know how many times families have come into our world and they've said, on WebMD, they said, if you stand grandma on her head and slap her 3 times, she's going to live for another year. and the doc goes, well, let's try it. And the rest of us are going, not so much. I mean, I always advise people to make sure that they have advanced directives.
Yeah.
And we call that the conversation. And that's, if you have parents, that's one of the things I would personally advise, that you actually sit with them for that conversation. You don't have to do it all on your own. There are people out there who can help you with it so that you really know their decisions. I taught an undergraduate course, and I was giving part of this lecture, and I said to the women in the class that the best thing a woman can do for herself is to have another woman girlfriend. And I said, simply because most likely your husband's going to be gone and we don't know where your children are at that time, if you've had any, but you probably need a girlfriend who's going to be hanging in there, who knows what's in your advance directive and can help you determine whether or not it's being acted out or not, or whether or not you're going to be used to stand on your head and do all this kind of stuff, and that's not the way you have decided to end life. So look at your advance directives, how they're updated and so forth. I know that's even more grim discussion than what we're ending on, but I think for those of us who've been involved with this for all my career, I just see so many people who have not started to think about this until it's too late. And my last note for you is that the Medicare has a wonderful hospice benefit. Hospice benefit is for 6 months of care. And if you don't like the benefit, the palliative treatment, you can go back to traditional. It's not like you're locked in for 6 months. But so you have 6 months of benefit. The average length of stay in a Medicare hospice today is
Less than 6 months.
8 days. And it's like, all right, now we've totally given up. And it's really too late for the types of palliative services this person could have had. So, you know, that's one of the other things that as papers you can start to bring out to start to have people think about what is the end of life going to be all about. It's going to happen. You know, the death and taxes. So if you don't want to talk about taxes anymore, you can talk about how to get people ready for this. So anyway, it's always been, I know I'm late, I really enjoy talking to you guys because I really feel that, like me, you're a voice that can actually get out to the community and help the community figure out what it's going to do next.
Absolutely. Thank you so much.
A new cup. Oh, thank you.